Yes, we
Okay.
can.
Thank you. It's really a pleasure to be doing a collaborative symposium with the All India Ophthalmologic Society. I'm going to be speaking today on pediatric herpes, a topic that is certainly challenging. I don't have any financial interest. The use of systemic Acyclovir is not approved by the FDA in the US for children, and I do receive some royalties for my my book on corneal disease in children. I'd like to begin with a case. This is a healthy 10-year-old girl who was sent to me urgently for unilateral viral conjunctivitis with the recent onset of corneal edema. The referring ophthalmologist thought that she had adenoviral conjunctivitis. She had had a similar episode 1 month prior, and her vision was reduced to 20/80. She also demonstrated reduced corneal sensation. On exam, you can see here a classic picture of a Wesley ring. And so my diagnosis in this setting was herpetic keratitis. I started her on oral Acyclovir and topical loteprednol 3 times a day. 4 days later, you can see that the ring is beginning to resolve and that there is some stromal edema consistent with disciform edema. She did well, and in 1 week, the steroid was reduced to twice daily. 2 weeks later, her vision had improved to 20/50. She had resolving edema, and I reduced her to loteprednol Q-day and a prophylactic dose of oral Acyclovir, which is 400 milligrams twice daily. She had a minor flare a year later, which responded to increased steroids, and she was stable for at least 5 years out on a very low dose of steroid and oral Acyclovir with excellent vision. So we know that herpes can be a very complicated disease in the anterior segment, and you can describe it many different ways: by the onset of its action, either primary, latent, or recurrent, by the location within the cornea, epithelial, stromal, or endothelial, or by its mechanism, infectious or inflammatory. Recurrent herpes simplex is quite common in children and manifests in multiple different ways, including blepharoconjunctivitis, various types of epithelial infection, stromal disease, and even uveitis. This is a montage of various forms of herpetic disease of the anterior segment. And so you can see here a primary rash, a beautiful dendrite, a geographic ulcer, interstitial keratitis with limbitis, disciform edema, a neurotrophic defect, and then focal limbitis. And we all know the end result of stromal HSV is a scarred vascularized cornea for which there really is no effective treatment, and we do try to avoid this. So a number of years ago, we did a large series of pediatric herpetic patients in Boston over a 10-year period. We had 53 patients. 4 of them had bilateral disease, so it was 57 eyes. The mean age was 5, but they ranged from young babies to teenagers. We had a long duration of follow-up of over 3 years, and most children had symptoms for about 2 weeks prior to presentation. 3/4 of them had a single manifestation, and 1/4 had multiple manifestations during their time of follow-up. The blepharoconjunctivitis was common in our series, and keratitis was really the most dominant form of infection. And most of that, 3/4, was stromal disease, including 20 of 29 IK and 9 of 29 other forms of stromal disease. More importantly, however, about a third were misdiagnosed prior to presentation. About 80% had residual scarring, with a half having a central scar. And because of the scarring and melting of the cornea, about a quarter had induced irregular astigmatism, also associated with a reduction in vision to less than 20/40. Of those who could be tested, remember these are children we're talking about, so it's kind of hard to test a 2-year-old, about 2/3 of them had reduced corneal sensation. Recurrence was high in this population, over 80% over the course of the study, which occurred at approximately 13 months. Treatment was with oral acyclovir suspension for young children and pills as children were old enough to take pills. Stromal disease and iritis were treated with steroids according to the clinical course. In general, acyclovir was well tolerated. The majority of children in our study received it, and only one had some GI upset in the setting of a pre-existing lactose intolerance. 16 children used it for 1 year or longer and had no side effects. This is from our paper. It's the treatment guidelines. And basically, I like to make things simple for parents. And we do this basically by half teaspoons or 2.5 milliliters and adjust the dose according to the weight of the child. There is a wide safety margin for acyclovir. Since we published our study, a group in Mexico has also presented similar results of about 100 patients, slightly older patients of 9 years with a shorter duration of follow-up. And they too found interstitial keratitis in quite a few patients and a high recurrence rate. Also, they showed reduced vision. So I'd like to continue with a few case reports that illustrate some important points. This is a photograph from an 8-year-old girl with a 4-year history of steroid-dependent keratitis. When I saw her, she had the neovascularization, decreased corneal sensation, and anterior stromal footprints that were very suspicious for herpetic keratitis. I started her on oral acyclovir, and for the first time in 4 years, her topical steroid was able to be reduced and eventually tapered off without recurrence of the disease. So her parents were very happy, as was the child. And she did well for a while until a year later when the flares recurred. She came back to see me, and in the interval, she had had a growth spurt, and such that her current prophylactic dose of acyclovir was insufficient to maintain quiescence. We upped her dose to the adult dosage of 400 milligrams twice daily, and she was able to become quiescent after that and stayed on that. So the important lesson that I learned from this case was, especially in children, you have to make sure that your prophylactic dose is appropriate. This is my most recent case of pediatric herpes, which has been quite challenging here in New York. This is an 8-month-old girl with a 1-month history of a red eye. She was not really diagnosed with herpes during that initial red eye, but she was subsequently seen by an outside cornea specialist who was suspicious of herpes and then sent to me. She was on oral acyclovir, topical steroid, topical antibiotics, and topical antiviral. She was found to have a persistent epithelial defect as shown here, and she in fact had dramatically reduced sensation because we were able to test her. Because we know that many topical medications can be toxic to the surface because of their preservatives, I reduced her topical medications, I added ointment, and I asked her parents to tape at night to encourage epithelial healing. Not terribly surprisingly, she couldn't tolerate the taping and came in a week later, and I placed a bandage contact lens with topical fluoroquinolone prophylactic therapy. The lens came out after 24 hours, and the PED was now larger, and you can see she had some anterior chamber inflammation. Now, of course, we were concerned that this might be infectious, and we did culture it, which was negative, and leading us to believe that this was all a sequelae from the persistent epithelial defect. We, at this point, took her to the operating room. You can see here a surgical view of her cornea. She doesn't have very much corneal thinning at this point, and we did an inlay-onlay amniotic membrane, the inlay in the area of the defect, the onlay over the entire cornea, and sutured at the limbus in a purse string fashion using 10-0 nylon. We also performed a suture tarsorrhaphy. She did very well with this, and about 10 days after we performed the surgery, we took her back for an exam under anesthesia, took down the tarsorrhaphy, and her epithelium had indeed healed. She did well for about a month, but then had very early breakdown. And thankfully in New York, we do have a center that fits the PROS lens. And I referred her to Cornell, where Michelle Lee, the contact lens optometrist at Cornell, was able to place her in a PROS device for continuous wear. And you can see her just from 48 hours of wear, the defect virtually closed. And she's been now maintained on the PROS lens and is doing quite well. Her epithelium is intact, and she's had no further breakdown. And of course, whenever we talk about any corneal disease in children, amblyopia management is a key part of the treatment. So in summary, herpes simplex keratitis is an important disease in children. A high percentage have stromal disease, and this has been shown in multiple studies. There is a high risk of recurrence, also confirmed in multiple studies, and a significant risk of corneal scarring, induced astigmatism, and reduced vision. Oral acyclovir can be used, and you must adjust the dose as the child grows. There is experience using long-term acyclovir prophylaxis if there is stromal disease. Of course, in children, you want to be careful with topical steroids, and amblyopia management is key. So in conclusion, herpes simplex keratitis can present in many different forms in children, and it's always a good idea to consider it in the differential when you have recurrent disease in the front of the eye in children, no matter what the manifestation. And a trial of acyclovir can be helpful in these very challenging cases. And I too, on behalf of the Cornea Society, would like to extend a cordial invitation to the rescheduled World Cornea Congress, which will take place preceding the annual Academy of Ophthalmology meeting in September 2022 in Chicago. Thank you.